Hi, my name is Andrew Aronsohn, and I'm from the University of Chicago, and I'm one of the co-chairs of the AASLD IDSA Hepatitis C Guidance. I'm happy to talk today about follow-up after the hepatitis C test and treat approach. First, a little bit about the hepatitis C guidance. This was a joint effort by the Infectious Disease Society of America and the AASLD that was launched in 2014 in order to have a place for recommendations for new treatment for hepatitis C using direct acting antiviral agents. This is a living document that can be found and is accessible to everyone online to offer up-to-date recommendations on how to treat patients with hepatitis C, and is really focused on providing clinical guidance for providers. What I'd like to focus on is some very, very new guidance that's available on the landing page of the hepatitis C guidelines, which goes into our test and treat approach using point of care testing. There is a previous lecture that talks about the first steps of the test and treat approach, including diagnosis and treatment. And I'd like to follow up with the follow-up after treatment is completed. The follow-up, our recommendation is also for the option to use point of care testing using the Xpert HCV platform. And as a review, this is a test where a fingerstick assay is done using a small amount of blood that is inserted into this cartridge that will allow for an HCV qualitative result within 1 hour. So results of SVR can also be found within an hour on patients who are part of this test and treat approach. And here is the second page of the test and treat approach, looking at follow-up after the completion of therapy. You can see at the very top, hepatitis C RNA 4 weeks after the completion of therapy. I'm going to show some data on the next slide about that. And this can be using a point of care test or a traditional venipuncture. If this is positive at 4 weeks, a specialist referral is recommended to be seen by somebody with greater knowledge of hepatitis C that can talk about next steps, including second-line treatment and understanding why treatment may not have worked the first time. If that is negative, this is a patient who has had a sustained virologic response or a cure. And it's really important at this point to identify patients that have cirrhosis. So the first half of the test and treat algorithm recommends testing with a FIB4. This is greater than 3.25, or the patient happens to have transient elastography done that is consistent with cirrhosis, or any history or clinical evidence of cirrhosis. These patients should undergo routine monitoring for hepatocellular carcinoma and decisions made whether surveillance for varices is needed. If they don't have those and they're not felt to be cirrhotic, then no further hepatitis C related treatment is needed. And further testing should be based on their particular risk factors they have for ongoing or recurrent infection. A little data about SVR4, since this is a change from the traditional SVR12. What we know is that there's very high rates of patients who are lost to follow-up for the SVR12 assessment. This has been rated as high as 62%. We all know that it is much more difficult to have patients coming back 3 months after the completion of their therapy versus 1 month. Very good news that randomized controlled studies have shown a greater than 99% concordance rate between SVR4 and SVR12. So the vast, vast majority of those who have an SVR4, you can be sure that they will have an SVR12. There's a very important caveat that the data is strongest in patients that do not have cirrhosis and who have not been treated with DAAs in the past. So an upcoming recommendation is going to be that quantitative HCV RNA through venipuncture at 12 weeks is still going to be an alternative for your patients, especially those that have cirrhosis or that have been treated with prior DAAs. But there also will be an option for SVR checking at 4 weeks as an alternative measure, again, for those that don't have cirrhosis and have not been exposed to a DAA in the past. It is important to think about some challenges on follow-up with point of care testing. And I do want to highlight thinking through how this information will be integrated into health information systems. There are some barriers with point of care testing as far as how do we make sure that this remains HIPAA compliant, and how do we link these results into our electronic health records, whether you're talking about a point of care test in a mobile unit or in corrections or at a health fair, and how to safely and securely report positive and negative values to public health entities that are gathering population-based data. So this is going to be a new challenge that will be unique to different health systems that are providing this care. So in conclusion, the follow-up after test and treat is very essential to determine a cure of hepatitis C. SVR4 can be used as an alternative to SVR12 in many patients, especially those that do not have cirrhosis and are naive to prior treatment. And at that time is a great opportunity to determine if somebody has cirrhosis and whether they'll have need for ongoing monitoring, as well as whether they have ongoing risk factors for infection and need for ongoing diagnostics. Thank you very much.